Hello, 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 and greetings to everyone. Thank you so much for joining the Melanated Hospice Nurse Podcast, where compassion and culture connect. I am Melissa Rowland, the Melanated Hospice Nurse, and I just want to say thank you all so much for joining this podcast. I also want to thank you for also joining the other podcasts, for going back and rewatching them or watching them for the first time, for sharing them with everyone, for re-listening to them. I can't thank you enough. The community is growing, and I'm so grateful and so thankful for all of your support, because I've said this from day one. The Melanated Hospice Nurse is not for me. The Melanated Hospice Nurse is for community. And I just thank God for allowing me to be a part of this. That's all it is. This is for everyone because it directly affects us all, uniquely and individually. So thank you all so much. I just want to do a little recap of last week's podcast. If you were able to watch last week, it was about culture, trust, and the healthcare system, and how all three of those elements play a huge role and whether or not we decide to come on to hospice. Culture, trust, and the healthcare system. We kind of dived in a little bit into what that means, especially with trust when it comes to our community and healthcare system, because we have hundreds of years of stories, interactions, engagements as to why we have this underlying tone of mistrust when it comes to the healthcare system. And the goal is trying to slowly regain trust, not so much with the healthcare system only, but trust amongst each other, because the commission is now for us to take care of one another. That's something that we've always done, and now it's time for us to return back to doing that. So that's what we talked about last week, was being able to really understand how that plays a role in us even choosing hospice care. Because when we hear the word hospice, we hear the word fear, we hear the word death. So how is it that we can actually trust that type of care when we don't have an overall trust of the medical system? And hospice has now been medicalized. It is very ingrained in the medical system. So because we don't have a big trust with the medical system, whatever entities are involved with that, we really don't have a lot of trust with that either. And hospice is included in that. As much as I wish that were not the case, that is the case, that hospice is a part of the medical system now. So therefore, we don't have a lot of trust with it, especially because of our relationships with the death and dying process. And that's something that the Melanated Hospice Nurse has been commissioned to work diligently to try to make an impact. We're just provoking thought and inciting change. That's what the Melanated Hospice Nurse is doing, provoking thought for us to think about the dying process and how we connect to that. Even before we were in this diaspora, how do we connect to the dying process? What were our cultural beliefs and values way before this whole process started? What was that like? And being able to return back to that, to the beauty of acknowledging death as a life's continuum. It is not an end. It's only an end to the life that we're familiar with, but it's the continuation of the beautiful life because of who we are. Now, I know a lot of us have different belief systems, and I don't really get into that. I do acknowledge it, but I'm not here to try to debunk all of the different belief systems. But I know that understanding that we are these beautiful entities, we are more than just the physical flesh that we see every day, and how we honor that as the dying process begins and how it continues into the afterlife, and how to be able to embrace the beauty in it all. So we talked about that last week: culture, trust, and the healthcare system, and how those three entities play a huge role in us deciding on coming onto hospice. So now this week's podcast, we're going to talk about, okay, so we've made a decision to come onto hospice. We've been given a prognosis of 6 months to a year or less. That's usually what it is. A lot of hospices are different, but for the most part, 6 months to a year or less. So here we are. 6 months to a year or less, we made the decision to now come onto hospice. So now what does that look like? When a person says, okay, I will accept hospice's services, what does that look like? Usually what happens is, in order for that process to start, it has to start with the physician's order. Anybody in the community can initiate a hospice evaluation. The neighbor can call and say, listen, they're my neighbor next door, I've noticed that they live alone. They've been kind of struggling a little bit. They've been wandering around. I've talked with them. Had a chance to talk with their doctor, and they're saying that there's nothing left more that they could do. The doctor mentioned hospice. I'm calling to find out more about that information. So the initiation of a hospice evaluation can be initiated by anybody. But in order for that to take place, in order for the actual admission to take place, it has to be generated from a physician's order. So we have to get an order from the doctor to say, okay, may we please come out and do a hospice evaluation. Once they get that order, then an admissions nurse will call, because that's a whole separate team, the admissions team. They will call the family or the loved one and say, listen, we've gotten an order from your physician. I understand that your physician has talked to you about hospice, because we're not just coming out here if you haven't heard of us yet. We want to make sure that it's clear to you that you've made the decision for the physician to go ahead and initiate the order, because the doctor has talked to you about what that means. Does that always take place? A little bit, but that's the goal. And then once the person or the family says, yes, we understand hospice, we would like for them to come out and do evaluation, because we need to know more about what hospice is all about. So once that order is initiated, here comes the hospice team, here comes the admission team. So here comes the nurse, the hospice admissions nurse, and she's gonna come to your home, and she or he is gonna sit down and ask you a series of questions to make sure that A, this is what you really want. Because everybody has an opportunity to deny hospice. Even once the admission has happened, you can still deny hospice. Even if you're into hospice, you can say, I no longer want it. No problem. So they need to come out, do a full evaluation to make sure that this is what you really want. They ask a series of questions. They go over all of your healthcare history to make sure that they get all of the information in order to develop a good care plan. So they get all the information, they call the physician back and say, listen, this is everything that I've gathered from this person. If the person is at home, a lot of the health history will come from that person or that family member who's able to give the hospice admissions nurse details about what their medical history looks like. Medications, medical journeys, surgeries, all of those different things. So they gather all of that. If the person lives in an assisted living facility or a long-term care facility, or even in a hospital, because a lot of admissions do take place in hospitals, then the nurse will go to the nurses there or the staff there. They'll gather the patient's chart, all their information, and gather as much health history as they can to make sure that they're getting all of the information so they can send that back to the doctor and say, listen, this is what we've gathered. This is the history of this person. This is their journey leading up to hospice admission. Do you think they qualify? The physician will then answer yes or no. According to everything that you've given me, the person appears as if they qualify for hospice. Once you qualify for hospice, now you'll be fully admitted to hospice's services. And we're talking about end-of-life care hospice. And what I mean by that, now a lot of hospices have different levels of services. Some of them are palliative care, which isn't end-of-life care. It's just managing an illness or disease that we know will no longer be cured or changed, but the person is able to exist in that new quality of life. So you have palliative care under hospice services, and then you have end-of-life care. I work in an end-of-life care part of hospice. I come in when the doctor has given you 6 months or a year to less. So I just want to make sure that people clearly understand that, because we also have home health, we have adult daycare centers, like we have a lot of different services now underneath the hospice or the hospice umbrella, but we have to make sure that people understand we're talking about the end-of-life care services. These are the services that we know we don't know. Forgive me for saying that, but these are the services where a prognosis has been given 6 months or a year or less to live, and now hospice is coming in to help care for you during that time. So once we get all that information from the admissions nurse, once the doctor says, yes, you're now admitted, what are the next steps now? What does that look like now? How do we go from, yes, I want hospice, to here comes the team coming into my home? What does that look like? The first thing I want to tell you is this: you are not alone. Let me reiterate that. You are not alone. And I say that because I can't imagine what that must feel like, to get someone or a doctor to sit down across the table from me and tell me, according to all of the things that we've done, every treatment that we have tried, and we have tried everything, it appears as if your body is not responding in a way that we hope that it would in order to sustain life. So now we think it's best for you to call in an end-of-life care service, more than likely hospice, and have them come into your home or into your setting, whatever that looks like, and allow them to care for you for the rest of your days. I can't imagine. I've never had that conversation. So for someone to go from hearing that to actually accepting hospice, What does that look like? So now that you've said yes to hospice, the admissions nurse has come out, you're giving them all the information, if your family you're doing it or the patient that's doing it, and now they're coming into your home. How does that look like? How does that start? So once you've said yes, me as the hospice nurse will receive that information. I'll get a full report on everything that admissions nurse has documented, on the diagnosis that now you are under hospice's services, and this is the diagnosis, all of your medications. I'll read over all of that. I will make a phone call to either you or your family member, whoever that person is that represents you, if you can't physically do that for yourself. And I will let them know who I am, introduce myself, and say, I am Melissa, the hospice nurse that I just want to call to introduce myself, to let you know that I have the honor of caring for your loved one during this journey. What would be a good time to come in and see you all? More than likely is usually the next day, the same day or the next day. Within 24 hours is when we actually go and see the person. I come into your home, I introduce myself. We have a chance to physically meet each other one-on-one, but you are not alone. I just want to make sure that I emphasize that, because I can't imagine what that must feel like. I can't imagine the sense of maybe loneliness, disbelief. Those stages of grief have now been activated. We know that denial and anger are the first stages of grief. So all of that now can be coming into play. But do understand that you have a hospice team. It's not just the nurse. I understand how people conclude that they think that it's just the nurse, because we're the ones that you're probably going to see on a more regular basis. But you have an entire hospice team. And the hospice team now consists of physician, because that's the person that I have to call in order to get orders to make sure that we're giving you everything that you need to be comfortable, whatever that looks like. So you have a physician, you have a registered nurse. Yes, LPNs also work for hospice, but a lot of the times, most hospices care module is set up so a registered nurse is a care team manager. But we also have LPNs that do the same exact job. A lot of the times they go in and do a little bit more because they're actually doing a little bit more hands-on, maybe wound care on a regular basis, and medication administration, whatever it is that the person needs. So I just want to make sure that we're clear about that. So more than likely it's going to be a registered nurse, but you're going to have a nurse coming in. So you have the physician, the nurse, you also have a psychosocial team. And that can include either a social worker or a licensed mental health counselor. And that person is also a part. So the core part of your team is the physician, the nurse, the psychosocial team, and the chaplain. Now, people hear chaplain, they start thinking religion. That's fine if that's what you need. But we also want to make sure that we're addressing your spiritual needs, whatever that looks like. So that's why we have chaplain services. And whatever your spiritual belief is, we're going to make sure that we're accommodating that to the best of our ability. So it doesn't necessarily mean religion. It means that aspect of who you are, that spiritual part, that we're not ignoring it, that we're also making sure that we're fully engaged in the entire human being that we're taking care of. So that's your immediate team: nurse, physician, psychosocial team, chaplain, and let me not forget who I call the soldiers of the team. Those are the hospice aides. Those home health aides, CNA, they are the backbone of our hospice team. Trust me when I tell you, I call them the soldiers, and I acknowledge them every chance I get. I make sure I let them know how much they are appreciated, because they're the ones that are going in and doing all that hands-on care, the bathing, the turning, the lotioning, the back rubs, all of that beautifulness that a person really, really desires when it comes to getting the care that they need. Those CNAs and HHAs are doing that. HHA stands for home health aides. CNAs is certified nursing assistants, depending on what hospice you work for. But when I tell you they are the soldiers of our team, the whole time I can remember the whole time during COVID, when we were all in COVID, we were all in lockdown during COVID, right? As nurses, we could do a lot of telehealth visits. We could go Zoom calls, and we can do all that stuff with the other nurses that worked in the building, because they were trying to reduce the amount of interaction that people had amongst each other, trying to prevent the spread of COVID. You know who couldn't do telehealth visits? Were the CNAs. How am I going to give a bath over telehealth? I can't. So the CNAs had to still go into these buildings when all of this lockdown was going on, and they had to put on all of this protective gear and still make sure that patient had TLC, still make sure that patient got a bath, make sure their skin was clean, their skin was taken, their hair was washed, their nails were cut, their nails were cleaned, feeding them. They did all of that while the rest of us had the convenience of being able to communicate through telehealth, communicate through Zooms. They could not do that. So when I tell you, every chance I get, I make sure the CNAs and the HHAs on our team, they are acknowledged for what they do. And I know I'm kind of harping on this for a long time, but I'm telling you, if it were not for those aides, a lot of the care that our hospice patients receive, they wouldn't get. Because as nurses, although we can do that, we can definitely do bathing. I love to do bathing with the CNAs. Sometimes I do it on my own. I don't care. If that's what the person needs, I'm there, I'm going to give it. But that's literally what they are on the team to do. And when I tell you, these CNAs are amazing. So for any of you out there that are CNAs or HHAs in hospice care, let me tell you, thank you. Thank you, thank you, thank you, because you are the soldiers. And every chance I'll get, I'll acknowledge that. So physician, nurse, psychosocial, chaplain, CNAs. And then volunteers are also a part of that team. So then we can start bringing in ancillary services as well too. But when I first started working for the hospice that I worked for 21 years ago, the statistic was something like this. 25% of the employees, the total employee population in hospice, were paid employees. 25%, if I'm not mistaken, somewhere between 25 and 50, but I'm thinking it was 25%. The rest were all volunteers. Volunteers. I'm talking about volunteers, pet therapy, music therapy, aromatherapy, massage therapy. These were all volunteers. The majority of the employees on the hospice that I worked for when I first started working for them were all volunteers. Only a small fraction was paid. So when I tell you this hospice could not exist without volunteers, unfortunately because of COVID, a lot of our volunteers dropped off because they were not permitted to go into the homes like they were before. So now we're recovering from that. And it's still recovering. There was a lot of fallout from COVID with the volunteer services. But volunteers, definitely, volunteers and CNAs were the soldiers, I'm telling you. So that's going to be your core team. So that's who's coming into your home when hospice has now been initiated and you've agreed to have hospice. That is your core team. You are not alone, and you won't just see me. Usually the nurse comes in once a week. That's usually when I come in, more frequently if need be, depending on what the care is. Psychosocial team, the social workers and the licensed mental health counselors, they usually come in twice a month, but they also tailor it according to the person's needs. Spiritual chaplains or the spiritual side, they usually come in once a month or more frequently. The chaplain on our team, he's busy and he knows every patient on the team. So they tailor the visits according to the needs. And the aides are the ones that usually go in more frequently, because we set the calendar for what the need is of the patient. So some hospice patients get showers or baths twice a week. Some of them get it 3 times a week. I've had to schedule aides sometimes 5 days a week, depending on that need, if there was no one there to help care for that loved one with those physical needs. So we tailor it according to the need of the patient. But that's very important as the admissions nurse, and then the primary nurse, which would be myself, what they call the nurse case manager. When we go in and do our assessment, we're able to assess not just the immediate care, but all of the needs that this person may need from now until the end of this journey. So that's who's going to come in. That's going to be your team. It's not just the nurse by herself or by himself. You have an entire team that you can access. So once we come in, we're able to do a full assessment of the patient. So that's the primary point. Second point is, what visits actually look like? What do hospice visits actually look like? So now that you've accepted hospice and you've met the nurse and you've met the team, what does that look like moving forward? What does it look like And that's what I say, that now we have to individualize the care plan. That takes a lot of intention, because it is so individualized. I've said this before, and you're going to hear me say it multiple times. There are approximately 7 billion people on this planet, 7 billion. Yes, as humans, we have commonalities. We have things that are very common amongst each other, because we're humans, right? But there's also things that are strictly unique to just who you are. And we know that because of thumbprints. When it comes to thumbprints, I use this analogy all the time. No, out of the 7 billion people on this planet, nobody has my thumbprint but me. That's how serious I take trying to personalize and individualize the care plan that person needs, because this process and this journey is as unique as they are. Yes, there are some common areas that we do share as humans, but there's also some places that nobody else shares but that person. That dying process is going to be as individual and unique as they are. So my goal and our goal as your hospice nursing team is to try to really be intentional with making sure that plan for you is as individual as your thumbprint. So that takes intention, it takes listening, it takes care, to make sure that we're not literally just treating you like something on a conveyor belt. Next, 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 next. How insensitive could that? You are not a car. This is not a factory. There is nobody else on this earth like you, and there never will be. So I need to make sure that I'm taking that into consideration when it comes to making sure that your care plan for you is as individual and unique as you are. But the only way I can accomplish that is by sitting with you, listening to you, or to your family members as they share about who you are, as you share about who you are, your fears, your hopes, your joys, your thoughts, your dreams, all of those things. And then bringing the entire team together to say, listen, this is what this person has shared with me. This is what we think we need to do to make sure that this journey is as peaceful and as beautiful as it needs to be. That takes a lot of intention. That takes us having meetings amongst the team, calling the social worker or the licensed mental health counselor, calling the chaplain, calling the home health aide, calling the volunteers, having these conversations with them. Hey, I met with this patient today and they share something very unique with me. And I think the entire team needs to know so we can all walk into their space understanding who they are. We can all be on the same page when it comes to caring for this person. That's how intentional we need to be when it comes to caring for you or your loved one when you come onto hospice. If that's not happening under your hospice care that you're on right now, call me. We need to get that right. We need to get it together. That's why it's important for us to take care of one another. That's why it's time for us to take care of each other in community. Because the community, we're going to make sure that don't happen. Oh, you're going to walk in respecting this person. You're going to make sure they get exactly what they need, exactly what they're asking for. When I first started working for hospice, it was so beautiful because literally we would help people with their almost like a dying wish. They wanted to go fishing. We would set up chartered fishing trips. If they wanted to go to the beach, we would get those beach wheelchairs with the big wheels that can roll over the sand, especially if they were wheelchair bound, to make sure that they can go to the beach. We would set up birthday parties, movie night, whatever it was that they wanted. Because remember, we're not trying to cure anybody anymore. We're past that. That's not what we're doing anymore. We're bringing quality to the days that are left. We're not trying to extend more days. First of all, we can't. We really don't know what days. That's all left up to God. But what I'm saying is that we were very intentional. So if you wanted to go fishing, we would go find someone that had fishing poles, a volunteer that can take you in their car. Like, it was so individualized. It was almost like make a wish. And our goal was to make sure that that wish came true, because this is not a dress rehearsal. We can't do this again. I get one shot. I say this all the time to my families and anybody that's working with me. We have one shot to do it right. One, there's no do-overs. There's no coming back from the grave and saying, okay, let's try it again. We messed up on that one. No, we have one chance to do it right. You deserve that. If you have agreed to having hospice come into your life to help care for you, correct? You've made that agreement. It is our duty, not our job. It is our duty to make sure that we are honoring what it is that you need to make sure that you have optimal quality of life for whatever those days look like. I'm not here to count the days, just here to make sure that the days are full of quality. That is it. That is what we have to do. So we come in, we spend time with the families, we spend time with the patient to try to really individualize and tailor that care plan to exactly what this person needs in order to have an optimal quality of life for whatever days they have left. And your entire team is working on doing that. Because you're not alone. Remember, this whole podcast is about the fact that you are not alone. You're not alone. So then after we do that, of course, the first thing we really do is when I walk into a room, my immediate thought is looking at you and seeing how comfortable you are. As soon as I cross that threshold, that is exactly where my mind goes. I'm looking at you. I don't even have to ask you the question yet. I'm looking at you and I'm automatically assessing for comfort, mental comfort, physical comfort, spiritual comfort. I'm assessing for that comfort because it's all about comfort care. Remember, we're not trying to cure. We're trying to initiate comfort. We're not taking away the hope of a cure. Please understand that. We don't take away someone's hope. That is not my goal as a hospice nurse. I don't take away your hope. If that's something that you want to continue to do, I will kindly step aside to make sure that you have every opportunity to do that. But while I am your hospice nurse, I'll make sure that our main focus is comfort. So I walk into that room, I say hello to you, and I'm immediately looking for comfort. If I don't see any, I'm going to ask you, how is your day going? 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 How is your are you doing? How are you doing? Listen to me. We're so used to the term, how are you doing, as a greeting, but we don't realize, and my father used to say, be careful when you ask that question because it's a question, it's not a greeting. So when you ask someone, how are you? Please don't just expect them to say, oh, I'm good, because what if they decide to answer the question? You know what? Let me tell you how I really am. Guess what you have to do? Now you have to sit and listen because you asked the question. So when I walk into your room and I ask you, how are you? And a lot of people will say, oh, I'm good. And I say, listen, out of due respect, I appreciate you answering that question. But let me tell you that it literally was a question and not a greeting. So I'm going to ask you again, how are you? 9 times out of 10, everything starts coming out now. They're like, you know what? I appreciate that. I appreciate that you literally want to know how I'm doing. Because we use that term as a greeting. So when I walk into your space, I automatically assess for comfort. That's the first thing I'm looking for is comfort, because a lot of the times it's nonverbal. We can pick up body language and cues to see, oh, wow, this person does not look comfortable at all. And a lot of times they don't want to tell you that because they don't want to feel like they're complaining. They don't want to tell you that they're not comfortable. So I have to be able to read that nonverbal body language, and I have to gently ease into that. I noticed that you slightly grimaced a little bit. I noticed that you've been shifting in your chair the whole time we've been sitting here. I noticed that you've been taking deep breaths. Are you comfortable? Opens up a floodgate. Here it comes, all coming out. But we, as hospice care team, we have to be intentional because remember, you're not a car on a conveyor belt. You're not a machine. You're a beautiful human being made up of so many different layers. And the goal in order to achieving your comfort is really getting to assess all of those aspects of who you are. And a lot of the times it has to happen immediately. As soon as I walk through the room, as soon as I see you, that's how quickly we have to assess. And then we gently ease into that conversation because it's already overwhelming that the hospice nurse is here. That's almost like, okay, well, there goes my life. It's a conclusion that my life is over. So I already know coming into your space that I'm already bringing in this concept, but I have to make sure I'm bringing in this beautiful energy to comfort, energy to ease anxiety. I have to do that with just my presence, not even my words, just my presence coming into your room, into your space. I come in so humbly. I try very hard when I do go in to see people, I automatically sit on their level. I do not like to stand over people when I'm talking to them. It's too intimidating. So I try very hard to make sure that I'm on the same level physically to make sure that that person automatically can exhale, understanding, okay, this person is here for me. So all of those little nuances really do play a role in that. So we're checking for comfort when we come in. So now you got your care team, you've agreed to hospice, the nurse is coming in, I'm automatically assessing because I have to individualize your care plan, correct? I have to make sure that this is tailored just for that thumbprint. Nobody else on this planet like you. Your dying process is gonna be just that beautiful. So that's a very important aspect for you to understand what that means when hospice comes in, because it helps to neutralize the environment because there's so much anxiety when hospice comes into your life. So much anxiety. Already what's been happening, your body's not responding the way you want it to. Now here comes hospice. So we just have layers on layers on layers of anxiety. So when I walk in, my presence has to be soothing to the environment. It has to be reassuring that I am not here to take over, that I am here to make sure that we are adding to your comfort and your quality. And you have to feel that immediately when I walk in. And I pray you do. I really do. I really pray that that's what you feel with the presence of hospice coming in, is immediate comfort. That makes my heart jump when I hear that. So then we have the aides that are coming in now. And I'm telling you, like I said, these aides are soldiers. So they come in to offer you that very personal, intimate care, because they're the ones that are literally doing the bathing and the showering and the shaving and the hair combing and changing of the briefs and skincare and rolling you over and checking your bottom and all these intimate places. And they're so good at gaining trust, because if you don't trust somebody to come in and take care of you, you definitely not gonna give me a bath. No, that's not happening. You know how intimate that is to give somebody a bath? A complete stranger. But these aides are just geniuses when it comes into coming in and saying, hello, my name is such and such, and I'm here to get, and they find so many unique ways on how to do that, especially with our patients that have dementia or Alzheimer's. They come in with these very unique ways of getting that person to be comfortable and to say, okay, even if it's not verbal, their body language says, okay, I will allow you to do, because that's so intimate, guys. Checking your skin 2 and 3 times a week. Now you can't control going to the bathroom, and now somebody has to come in and now clean you. Like, seriously? You know what type of trust you have to have for that to happen? So I pray and I talk, me and the aides and the social workers, we have these conversations. Our energy has to be very soothing when we walk into your space. It has to be very humbling, because we don't want you to think that we're coming in to take over. And I know, trust me, I've worked with hospice nurses who come in and take over. And every now and then I have to gently pull to the side to say, can we talk? Especially when it comes to our communities, because there's just certain things you will and will not do. What you will not do is walk into a home and call an elder by the first name. Never. That's another level of gaining trust. So every now and then I have to have conversations with other cultures to say, listen, this is how we do it in our culture. When you enter into a space of an elder, you will address that person by Mr. or Mrs. You will not address them by their first name. When you come into the space, if their shoes are on the front porch, you're going to take your shoes off. You won't put your bag, you won't sit on their bed. You won't put your bag or your luggage on their bed. You will ask for permission to wash your hands. And more than likely, you need to go into the bathroom and not the kitchen sink. All those little nuances. That's a whole nother podcast. But those nuances are very important when it comes to gaining trust. When it comes to gaining trust, especially in our community. When it comes to gaining trust, enter into that space with a soothing, comforting energy, because trust is earned. It is not automatically given. It is earned. And I know when I walk in and say, hello, my name is Melissa. I'm going to be your hospice nurse. That sentence, that phrase, there better be such a level of trust and comfort in my voice and delivery, because that person's response has to be welcome in. Because if I come in with any other attitude, you have every single right to say, you know what? I don't think this is gonna work. So I literally have 5 seconds to gain your trust, at least to open up the area for trust. That's part of that individualized care plan. That's your team coming in. Social workers, they come in with resources. Love our social workers. I'm going to say psychosocial team. Our psychosocial team, because it's social workers, licensed mental health counselors, marriage counselors, family counselors. So there's different levels of counseling, different titles, but they come in for a lot of the emotional support, a lot of community resources. I call on them to say, listen, this person, I literally had a social worker, we had a patient, he didn't have a cell phone. He had no way of, and he was in like an independent community style. So they were really responsible for their own forms of communication. He had no access to a cell phone. She worked diligently to fill out an application to make sure that he got a cell phone. Free of service and free of charge. She was amazing. She was an amazing social worker. The one that I work with now, chef's kiss. Chef's kiss. Absolutely chef's kiss. So everybody in your team has a very vital role when it comes to making sure that your care plan is individualized, that your care plan is your thumbprint. Nobody else on this earth like you. Neither shall your care plan be. Hospice is available 24/7. 24/7. I tell families all the time, I'm not available 24/7. Remind families, no, I'm not available 24/7. Is there anywhere you can call Melissa 3 o'clock in the morning? You can call at 3 o'clock in the morning, but I won't answer. So the team is not available 24/7, but hospice services are available, because we have an evening and weekend team as well too. So when I work from 8 to 5, after 5 p.m., there's an entire evening team. We call it evening weekends because the weekend, that team is all included in that. So from 5 p.m. to 8 o'clock the next morning is an entirely different team. Now, they're not made up like a core team, but a chaplain is available. A nurse is available. Social worker is available. Hospice aide, not so much, because of the care that they administer is usually personal care. And usually people call after hours is more emergency. Anything else would be diverted to the next morning for the team to take care of. So usually the after hour team is set apart for emergencies. Yes, we have chaplains and social workers because people normally die after hours. So you still want that support that you would have. You need that psychosocial support to come out at the time of death. You want the chaplain to come out at time of death. There's a nurse at the time of death. So you have that. We even have volunteers that do agree to work the midnight hour because that's when they're available. They can go sit with families. They can be there for a loved one if they need to be, but it's usually on emergency basis. It's not so much scheduled visits like we do during the day. That's how the hospice that I work for is set up. That's how it's set up that way. So we are available 24/7. But remember, we don't move into your home and take over. We do not. We partner with the patient and the family. We are partners. We are not taken over. No one should feel like hospice is coming in and taking over their care. If you feel that way, then either you or a family representative needs to have a conversation first with the nurse. Excuse me, but I just feel like I don't have much of a say-so on what's going on. I know we have no control over a lot of what's going on, but at least should have some say-so. I should at least have say-so on what's going on. If you feel that way, either you or a family rep, I'm begging you, say something. You live all the way in Michigan. I'm talking to your hospice nurse. Hey, listen, I just got a call from my auntie. I'm going to call everybody auntie and uncle. So if you call me and you're a man, you're going to be my uncle. If you're a woman, you're going to be my auntie, or you're going to be my cousin. I just got a call from my cousin. They said they're not feeling very comfortable with the care that they're getting. What's going on? Trust me, I will have that conversation. I don't play about my community. I do not. Not when it comes to that. When I worked in a hospital setting, no, members of my community come in, I automatically go into family mode. That's my family. That's my auntie. That's my uncle. That's my ma. That's my dad. That's my cousin. They're like, you have a lot of cousins. Because I do. I have a lot of cousins. And we're going to make sure cousin is good. Not when it comes to community. No, because we get no do-overs. We may have been mistreated in the medical system, but we're not going to be mistreated underneath my watch. It's not going to happen. I hope that doesn't come across as arrogant. I hope it comes across as compassionate and loving. I've seen it happen way too many times. I've heard all the conversations behind closed doors. I know what goes on. So I really advocate to make sure that all care is equal. I don't care who you are, the care is going to be equal, but especially when it comes to my community. You're going to get optimal care. That's what I've been commissioned to do as a hospice nurse. That's my calling. And that's what we're going to make sure happens. So another aspect of what families can expect coming into hospice is comfort, dignity, and quality of life. Quality of life. We call it QOL. I'm so used to saying QOL. Quality of life, comfort, dignity, and quality of life. Because remember, we're not trying to cure. That's not what hospice is all about. I'm going to say it again. We're not trying to cure, but we're not taking away your hope of a cure. If that's something that you still want to fight for, you let us know. Hospice will step aside. We will pull back all the services and allow you to continue to fight for whatever you need to fight for. And a lot of people, not a lot, but people do make that decision. They come on the hospice care. They feel that, this is what they were told they needed. And now they think, you know what? I want to keep trying. Because we're not here to snatch your hope away. That's not what we're here for. But we're definitely here to make sure that you have comfort, dignity, and quality of life. And that dignity part is so important to me, all the way down to how you receive a bath. When I am assisting an aide or bathing someone myself, that's one thing I can say that I kind of miss from bedside nursing, was the ability to spend time with my patients during giving them ADL care, which is activities of daily living. And anytime we would administer bathing, setting them up to get ready to do their morning care, brush their teeth, shave, wash their hair, put their clothes on, lotion their back, all of those beautiful TLC moments is what I call them. I find that probably the most humbling as a human being is to have someone else come in and care for you in a way like that. But to maintain a person's dignity during their bathing time, to me, is so important. Please don't keep them completely naked while you're bathing them. Cover them up. Whatever spaces you can cover them up with. Please talk to them in a dignified way. Please don't talk to them as if they're a subject. Talk to them in a dignified way. Let them know what you're going to do before you're going to do it. Mrs. Jones, I'm going to turn you over right now. I need to wash your back. I need you to grab that rail over there. I need you to help me turn. Once you do that, it keeps reducing the levels of anxiety, but it helps to increase the trust and it maintains their dignity. We are here to maintain your dignity as a human being. You're not my subject. You're not just another person on my caseload. And we can have heavy caseloads. Sometimes I have 25, 30 people on my caseload. But when I come to your space, it is just me and you. It is not the other 29 people. They're going to have their own time. Please do everything you can to maintain that person's dignity all the way down to the bathing. To me, that's the most important. What we do when it's just me and that patient and maintain that, to me, is so important. Please don't have conversations across the person with somebody else in the room. Please acknowledge them in the bed as you're talking to somebody else. Mrs. Jones, I'm sorry, but I just have to let somebody know that this is what we're doing. Yes, ma'am. Absolutely. Or include Mrs. Jones in the conversation. Or wait till you leave the room to have the conversation. Please maintain a person's dignity in every single arena that you can. That's what hospice is coming in for. Comfort, dignity, and quality of life. How dare I go in there and treat you like you're a subject? How dare I do that? This is a part of your journey. We don't get a do-over. I sometimes go overboard, I think, but I can only imagine if that were me in the bed. When I train new nurses coming into hospice, I have a person that's training with me right now. She's a new nurse to hospice. She's a new RN. She was an LPN for years. She worked in long-term care settings. Now she's an RN and she's coming into hospice. The first thing I tell them, when it's your turn, because your turn is coming, when it's your turn to be the hospice patient, to be in this bed, can't get out of bed, can't feed yourself, can't really communicate, you're incontinent, you have to wear adult-style briefs, you have to have somebody come in and turn you and bathe you and feed you and make sure that you're comfortable. When it's your turn, because your turn is coming, when it's your turn, who do you want to come in and take care of you? Who? You know what my answer is? Me. You know what that forces me to do? It doesn't force me to do anything, but you know what that helps me to do? It helps me to make sure that I treat every single patient as if it were me, because one day my turn is coming. And I don't do it just because of that. That's not what I'm saying. In spite of that, I do it. Who do you want to come in and take care of you? So think about the kind of care that you're given, because that's the kind of care you're going to receive. So when I'm taking care of someone, I put myself in that bed. I put my dad, my mother, my siblings, because what you're not going to do is mistreat them in any way, shape, or form. And you're going to maintain their dignity and their quality of life. I'm going to make sure of it, because that person has trusted you. I tell my new nurses this all the time. That person has trusted you. And when they're laying in that bed, they're at the mercy of a stranger. And depending on what type of day that stranger is having is the type of care that person's going to receive. That to me blows my mind. I'm at the mercy to the kindness of a stranger. And if that stranger decides they don't want to be kind that day, guess what happens? So I'm constantly challenging new nurses. Who do you want to show up at your bedside to take care of you? Do you want you to show up? And it makes you stop and think, well, what kind of care am I actually giving? I don't know. What type of care are you giving? Only you can answer that question when it's just you and that patient by yourself in the room. And now a lot of families are putting cameras in rooms. I don't blame them either way. However, whatever you need to do to make sure that your loved one is getting the best care that they need. So we have to maintain that dignity, that comfort, that dignity, and that quality of life, because it's comfort care versus cure. That's what hospice is all about. Helping to manage your symptoms. And when we talk about symptoms, the most glaring ones are usually pain. That's a tough one. Because of course we first think physical, that physical pain that a person's having, we think physical. Yes, but then there's emotional pain, there's spiritual pain, psychological pain. There's different arenas of pain, and sometimes they all come through the physical. So now we're trying to treat the physical, but we're not quite getting it comfortable. We're missing it. We're not quite hitting the mark here. And families are like, why are they still so uncomfortable? And we're like, you know what? This seems like it's more than just physical. This might be a spiritual pain. This might be something that only that person can resolve through whatever their belief system is. So then we send in chaplain to say, listen, this person is really struggling spiritually. We believe, because we tried all these medicines and nothing's helping to soothe or comfort them. Once again, that's being very intentional to that individualized care that human being needs. Not everybody else that I've taken care of over the past 30 years. That's why I'm always fascinated by every patient that I get, because it's going to be something different. I've been doing this for almost 30 years, and I've never seen two deaths be alike. Never. A lot of similarities, but there's also those uniqueness that we cannot overlook. We have to be very intentional with that. So the goal is to make sure that you're as comfortable as possible. And we have to make sure that at hospice, we're not trying to add days to your life. Hear me when I say this. My goal is not to add days to your life, because I have no control over that. My goal is to add life to your days. It is not to add days to your life, but to add life to your days. People often ask when I come in, what is your goal? My overall goal as your hospice nurse is to make sure that we are adding the optimal quality of life to whatever days you have left. I am not here to make you die. I'm not here to do that. I am here to help you live until you die. I am here to help you live until you die. I am not here to make you die. I am here to help you live until you die. My goal is not to add life or not to add days unto your life, but to add life to your days. That is it. And that's a conversation that we have when we meet each other. It takes time to get there. And when the time is right, that is what we discuss. So what can families expect when coming onto hospice? They can expect a hospice team. They can expect what visits actually look like. They can expect comfort, dignity, and quality of life. And they can also expect support for caregivers. All you caregivers are soldiers. Woo! Caregivers, let me tell y'all, when I say kudos to caregivers, I'm shouting that from the mountaintops. Kudos to caregivers in whatever aspect or arena you're caring for that loved one. Kudos to you, because that is sometimes a thankless job, but it's such a labor of love. It's not a job. It's just a term that I'm using, but it's such a labor of love. Caregivers. Physically exhausting, emotionally exhausting, but you hang in there. You hang in there to the very end for a lot of caregivers. Wow. I'm telling you, the caregivers, because they are outside of the patient being the core person of this whole process, right? The caregivers. When I tell you I'm hugging every caregiver right now that's in this space, do know that you are seen, you are acknowledged, you are supported. This is not easy. Caregivers, it is physically and emotionally exhausting. And so many times the caregivers neglect themselves. Because all I know to do is care. I don't know anything else. That's my mom. That's my husband of 65 years. I have a family right now. The wife is a nurse. They've been married for 65 years, almost 70 years. All she knows is how to care as a nurse, as a wife, as a mom. But she's caring to a point where she's becoming physically exhausted. Her children have swooped in, but they've been there the whole time. A lovely family, very supportive care from all the family members. But they said, Ma, we're coming in right now because you live out of town, so on and so forth. We're coming in right now and we're gonna be with Dad. What you're gonna go do is you're gonna go to lunch with your girlfriends. You're gonna go to sleep. They're hiring somebody privately to come in the evening time to make sure that she can get some sleep because she's almost up 24/7, just worried about him. Caregivers. And I know a lot of caregivers, they don't want to ask for help, especially the older generation. Us younger generations, we're like, I need some help. But that older generation, they're not used to asking for help. For a lot of them, it feels like a sign of weakness, like I can't do it. They don't want to feel like they're weak, so they don't ask for help. But I have to constantly reassure them that weakness, asking for help, is not a sign of weakness. Asking for help is a sign of wisdom. Listen to what I'm telling you. Asking for help is not a sign of weakness. Asking for help is a sign of wisdom, because we were not designed to navigate through this life alone, especially when it comes to the end of life process. I'm not saying that people don't have a choice to be alone in this life. Please, I get that. That's not what I'm talking about. But when it comes to this dying process, it is designed for community. Community has to pull in to help with this process. So asking for help is not a sign of weakness. It is a sign of wisdom. Wisdom. So caregivers, at our hospice, we have what they call caregiver coffee supports once a month, and it's facilitated by the psychosocial team. And what they do is they have meetings, they call them caregiver coffee breaks. And they have it once a month at a designated location. Usually it's at the hospice center, but for the most part, it can be anywhere they design it, anywhere they designate it. And the caregivers come and they're able to unload. They're able to lean on one another. I often tell caregivers, I really hope that you can find it in your heart to go to one of these supports. You don't even have to talk. Just sit in the presence of other caregivers and breathe. That's all you have to do. Breathe. Just sit in the support of other caregivers. If you want to talk, you can talk. If you don't, you don't have to. But please take advantage of these caregiver coffee supports. Now they have caregiver cafes around. They have them online for people that probably can't drive, because we do have an older population and they no longer drive anymore. So they can't readily just get up and go to these coffee supports. But they do. A lot of buildings that I work in, a lot of ALFs and long-term care places now have caregiver supports on campus. So I'm constantly encouraging caregivers. I have one, she's a daughter. We're about the same age, in our 50s. And I'm constantly encouraging her. Now she's meditating. She takes yoga classes. She goes to counseling, because she was just crumbling underneath the care of trying to be there and be everything for her mom. And now she comes in and her energy is different. She's smiling, she's happy. Yes, still very sad about what's happening with her mom, but she's feeling more empowered that she can do this, because she was literally emotionally crumbling under the weight of all the grief of trying to do this alone. So that's part of the hospice team coming in and making sure that we're assessing the entire situation when it comes to caring for you or your loved one. Caring for the caregivers. That's very important for me, because if the caregiver crumbles, who's going to be there for the patient? The caregivers are the pillars. They're holding everything up. So I'm really big on making sure that we're supporting these caregivers and that you're not alone. And the last takeaway when it comes to what families can expect when coming onto hospice is the inevitable, if it's going to happen, right? And that's, what can I expect at the end? What does the hospice team look like? What does hospice care look like when death is near? When my loved one is now imminent, is what we term it. That's when death is near. Death is really near, within 2 weeks or less. What does the hospice care look like? I can tell you. So when I go in and I can see, just through assessment, and you can kind of see it coming on the horizon a little bit, you just have to be very in tune to that loved one or to that patient when it's happening. But you can kind of start preparing the families. And there's a book that we use a lot called Gone From My Sight, written by Barbara Kearns, who is the guru of hospice. I love listening to her podcast, but it's called Gone From My Sight. And it's a book, it's a tool that we use to give families a little bit of insight to what's happening when it comes to months, weeks, days, and moments when death is coming, what that loved one is experiencing, what changes take place, what they're doing, what we can expect. These are the commonalities of us being humans. So commonly, we usually see these things happening. Eating will decline, sleeping will increase, people will become less engaged in external environment, more inward, becoming less verbal, less interested in things that used to interest them. And we're going to do a whole podcast on that. I'm looking forward to that. Those signs that things are happening, that death is becoming near, that they're now surrendering to what's happening in their body because it's bigger than them. It's bigger than them. They can't stop the process from happening. So when I see that start to happen, I start to prepare the families. Listen, I think he or she is getting close. And this is what you can expect from hospice as this is happening. You're going to expect visits to increase. When a person is now imminent with hospice, once I go in and I look and I say, whoa, they're imminent, automatically the nursing visits or the visits become daily visits. And the daily visits on the hospice that I work for include the psychosocial team and the nurse. We alternate days that we go. For nurses, I go Monday, Wednesday, Friday, Saturday, Sunday for the weekend team. And psychosocial is usually Tuesday, Thursday. Chaplain can go in at any time. Hospice aid frequencies will normally increase because that person is now in a state where they probably need a little bit more personal care. They probably need baths a little bit more frequently to make sure that their body is clean and comfortable. Their sheets are changed, their pillows are fluffed, their skin is intact. So a lot of the times I may increase the home health aid visits from twice a week, if that's what they were getting, to maybe 3 to 4 times a week. So we tell the families, you will be seeing more of hospice's presence because we want to make sure that that person is getting everything that they need. Because remember the thumbprint, guys, this is uniquely them. There are no do-overs when it comes to caring for someone that's transitioning. They don't get to die and come back for me to get it right. Nope, I got to get it right now. And I'm going to do everything in my power to make sure that those days are full of life until your last breath, until your very last breath, down to soft music, soothing hand holding, quiet environments, all of that. So we start to prepare the family, call your loved ones, because that's usually do you think I should call my brother who's out of town? Anytime a family member asks me that, I always say yes, always. If they come and nothing happens, well. But if they don't come and something happens, 9 times out of 10, a person cannot live with that guilt. So when they come and say, Melissa, listen, do you think I should call? Yes, call him. If he can make it, tell him to come on down. And I usually say down because everybody lives up north and we're in Florida. So I can say that. Tell them to come on down. Yes, yes, yes. Because there's something inside of you that made you ask that question. I do not say no. No, I think, yes, they should come down. Now, if they decide they don't want to come, that's completely up to them. But as time gets close and the family start asking that question, should I have my? Yes, you should. If they're able to come, have them come. If they come and the loved one does not transition while they're here, at least they had a chance to spend time with that loved one. But if they don't come and that loved one has transitioned and I said, no, don't come, I couldn't live with that guilt, first of all. I couldn't live with that. But I know a lot of family members carry that guilt with them that they were not there at the end of life when that person took their last breath. Because we all would like to be there, if that's what we so choose. Not everybody, let me not say all, because for some of us, it's too hard to be there. And I get it. I have family members that say, I can't come. That's okay. You don't have to. And that is too much for your heart to take. It is perfectly fine fine. You don't have to come. You don't have to. That person knows that you love them. So we're not here to judge that. We're not here to say, oh my God, he didn't make it. That is not our job to do that. You're not walking in his shoes. You're just taking care of his loved one. So save your opinions to yourself. That is not my job to judge you whether you're coming or not. If you ask me, do I think you should come? I'm more than likely going to say yes. If you can make it, you can make it. If you can't, you can't. I will stay in constant communication with you. Some families I even FaceTime, so they have a chance to talk to that loved one over FaceTime. Thank God for technology when it comes to that. I am not here to judge that. That is not my journey. That is not my job. I'm not here to judge that, because what am I going to do when it's my turn? How do I know how I'm going to respond and react? And I say that because when my dad died, during his funeral, I literally got up and walked out. I could not take it. I was overwhelmed with grief. And I felt that if I stayed there, because my dad was a jazz musician, and during his funeral, his best friend, one of his best friends, played a song that my father loved to play for my mother called Beautiful Dreamer. My dad played upright bass, and he played that song with his bow, and it was the most beautiful song. And it was one of my mother's favorite songs. So in tribute to my father, his friend played the song Beautiful Dreamer during the funeral. I got up and walked out. I thought I was going to lose the breath in my body. I was so overwhelmed with grief. I never would have thought I would have done that. But I did, because I knew if I stayed there, I was going to pass out, and then it would have been about me and not about my mom and my dad. So I am not here to judge someone on how they react and respond to that loved one during the dying process. I'm here to support you through whatever you need to do to get through it. It's heavy. It's heavy in ways that I can't even explain, because I experienced that with my father, who I just adored dearly and miss him every day. So I'm not here to judge you on that. I'm here to support you through it. So that's a part of knowing what to expect toward the end. So what can families expect from hospice? First, the goal is to come in to help remove fear. That's my goal when I come in, to help remove fear. That's my goal. You can expect your hospice team, your physician, your nurse, your social worker, your hospice aide, your psychosocial, I said social worker, and your chaplain and volunteers. You can expect that. You can expect your visits. We sit down and talk about the visit frequency and what actually happens during the visits. When nurse comes in, I'm there with the patient every time, assessing for comfort. That's the first thing I do. I'm assessing to make sure you're comfortable. So now you know what to expect from the visits, right? What to expect from the visits. You can expect for comfort, dignity, and quality of life. Comfort, dignity, and quality of life. You can also expect for caregiver support. Ooh, these caregivers. Caregiver support. Absolutely caregiver support. And then you can also expect what's going to happen near the end, or when the end time comes, what to expect. But do know that you're not alone. You are not alone in this. Not under my watch. Y'all hear me? It's not going to happen. And I say that with such humble conviction. It's not going to happen under my watch. You're not going to feel alone with this. I want you to feel very supported. I want you to tell me what it is that you need. Melissa, I think we need this. Okay, let's try to make it happen. I know that this is a very intimate, vulnerable time for families. You have to open up spaces that normally the public wouldn't know, especially a stranger. And my goal is always, when I come into your space, I may enter as a stranger, but I will leave as a friend. And a friend is someone that you can confide in and that you can trust. And I have developed some beautiful relationships with the families over the years. Some I still keep in contact with. I mean, respectfully so. We have to have boundaries. You can't, that's a whole nother podcast for another day. Because I've seen some boundaries that have been crossed. It's like, oh, we got to be careful with that. And I get it. Because we're coming into your space that's a very intimate time in your life. You feel very vulnerable, so you open up to us. You share things with hospice that you wouldn't share with anybody, because we see a side of you that the rest of the world doesn't see. And I take that very seriously. And I protect that. That's very confidential. That is not for me to discuss with anybody but you or family. Even within families. Sometimes the sister will confide in me. I don't go tell the brother. That's between family. That has nothing to do with me. If the sister tells me something in confidence, it stays in confidence. If the brother tells me something in confidence, it stays in confidence. I don't cross those boundaries. It's taken, but that takes years of experience and just years of experience to come to that. But it's a trust, because trust is gained, and I have to earn your trust. In my introduction into your home, hello, I'm Melissa, your hospice nurse. Just from saying, hello, my name is Melissa, I'm your hospice nurse. 9 words. I got 9 words to gain your trust. That is it. And that's how I think about it. When I call on the phone, hello, is this such and such? Yes, it is. Hi, I'm Melissa. I'm your mom's hospice nurse. I was just calling to say hello to you. Thank you so much. Thank you for calling. You see, because that trust has to be earned immediately. That's how I think. Now, for some people, it may not be that way, but for me, it has to be. In order for you to tell me everything that you've been going through in a 15-minute phone conversation over the past 10 years with your dad, there better be a level of trust there. And I don't have much time to gain your trust. So for those of you that I've taken care of in the past and you've trusted me, thank you, because that's not easy. And I don't take that lightly. Thank you for allowing me to care for you and your loved one. Woo! Love it. Love this. So that's what you can expect when you decide to have hospice come into your life. Those 5 key takeaways. But you know what? I cannot believe that we have come to the end of our first month of this podcast. Yeah. Give yourselves a hand. And the crowd goes wild. I need one of those machines and you have crowd noises like everybody's cheering in the background. I can't believe that this is the 4th episode. Well, you know what? I'm not really calling them episodes. I'm calling them soulful series. This is our 4th soulful conversation. So the month is soulful series and then the episodes underneath are soulful conversations. Just trying to be different, but yes. So we have completed our first soulful series. I love that. So already we're coming into July. Listen, we are already into July almost. Is that not crazy? We're coming into July. And I say that because anybody knows me, I love Lifetime movies, right? And they always start showing the Lifetime Christmas movies in July. If I had my way, I would go live in a Lifetime movie town. Crazy, I know, but it's always so peaceful. I love Lifetime movies. But we're coming up on July already. So July is going to be an entirely new soulful series. Soulful series number 2 coming up. And what we're going to focus on for the entire month of July in that soulful series is redefining strength. Does choosing hospice mean that you're giving up? Ooh, surrendering versus support. Redefining strength. Does choosing hospice mean that you're giving up? Surrendering versus support. That is month number 2, soulful series. And then we're going to have 4 soulful conversations underneath that monthly series. So I just want to say thank you so much. Thank you for coming on to the Melanated Hospice Nurse Podcast. It has been my mind is blown. I'm talking about blown by the amount of response and support and questions. Don't forget, Thursday, we go live. We go live Thursday. Let's talk about it Thursdays. I want you to listen to this podcast, what families can expect when they come onto hospice, the 5 key points that we discuss, and I want you to jot your questions down. When we go live on Facebook, the Melanated Hospice Nurse Facebook. We go live on Melanated Hospice Nurse YouTube. We go live on the Melanated Hospice Nurse Instagram and Riverside. We're streaming to all 4 of those platforms at one time. When I go live or when we go live Thursday, put your questions in the comment sections. If you're on Facebook, Instagram, and YouTube, put your comments in there. I'm going to be able to see the comments. I'm working on that, but I'm going to be able to see the comments and then we can interact back and forth. I'll be like, hey, John, yes, I see you have a question. My mom was on hospice. This is what happened. Put that in the comment section and I'm going to try my best to make sure that we address those. I'm not going to hold you long on Thursdays because we go Thursday live at 8:00. So I'm not going to hold you long, but I do want to make sure that we're able to have these conversations. So it's called Let's Talk About It Thursdays, where we go live and we actually talk about the soulful conversation that we had the week prior. So we have the soulful series, which is what we talk about, the monthly theme. And then every week we have a soulful conversation. Okay. But before you do anything, I want you to like and subscribe. They always hit the button below. Hit the button below. I love that. Hit the button below. Like and subscribe to the YouTube channel. Please share this with others and have them subscribe as well too. We're going to do a whole YouTube subscribing campaign. I can't wait for that, but I'm loving it. So I need you to do that. Like and subscribe, right? Share it. Watch it again. Ask the questions. Put them in the comment section because this journey is getting ready to be beautiful. It already is beautiful. It was beautiful before it started, because it was ordained way before me. I'm just thankful that God chose me to be a part of this whole process. So the Melanated Hospice Nurse Podcast, we are all about community. We are about taking care of one another. We're about having open dialogue about the dying process to make sure that it can return back to its splendor, its glory, and its beauty. Doesn't that sound morbid? But it's gonna happen. So why shouldn't it be, right? But before we say goodnight or before we close, I just want you to take away with this. May compassion guide you and may culture ground you. Bye for now. See you next week.